So we're going to talk about, we're going to treat 55mm AAA in a 64-year-old gentleman that is obese, has COPD, and a history of pulmonary embolism and high blood pressure. Next, please. So this was the pre-op workup. So you can see that he has a diseased left internal carotid artery, but we decided that it's asymptomatic. We're not going to treat him. Renal function is okay. And so the ASA score from the anesthesiology was 3. Next. So this is the pre-op CT, and the issue with this patient is access. You can see the ilex are diseased, and that's why we believe that a low-profile delivery system is adequate for this gentleman.
Can I ask you right away, because this is the nice session, whether you chose an EVAR for this patient because of the comorbidities that you presented, or is that a standard of care in your center?
So for this patient, there was no discussion because of his BMI and COPD.
Okay. So
but for a 64-year-old patient with no such history, we would have a discussion with the patient talking about pros and cons of open and endo. Now, this is probably a good mask that I can trust 100%. So I'm going to start opening the endograft, tu tiens bien le guide, positioning the markers at the level of this purple line, which is a line now because I'm in the good position. And I'm going to slightly unsheath. You will see the proximal uncovered stent slightly opening, and then the first sealing stent opening. Donc tu vas m'enlever les marqueurs. Now I want to check that I'm in a good working position. Ils sont encore là. Tu me les enlèves, s'il te plaît? Merci. So I'm checking that, looking that the 4 markers are actually lined up. So they're not perfectly lined up. I'm going to slightly change the angulation. So probably this is not too bad. And I'm going to shoot a new angio to check if the graft is in the right position. Une apnée, s'il te plaît? OK, merci. Il peut respirer? So obviously I'm slightly too high here. Well, not really too high, but I don't need to be sharp just below the renals. You remember he has a long neck. So I'm getting the device slightly down here. And now I'm happy with the position. I'm going to finish unsheathing the graft until the short limb will open. Voilà, tu me tiens ça, s'il te plaît? Petit rhumeau. So I think there's no issue. We're just below the renals where we want to be. You can see that the 2 limbs look nicely open and that we have flow to both internals, and I don't see any endo leak.
The conclusion of this analysis done by the very clever people at NICE is that a rerun of the EVAR-1 trial would be very unlikely within the UK healthcare environment to show that EVAR could be cost-effective at current UK NHS willingness to pay thresholds. So logically, and looking at the science, no NICE advisory committee could advise NICE, could advise the NHS to purchase an EVAR procedure if a patient can be treated with open surgical repair, and hence this recommendation at the bottom.
You've charged me with the goal of saying whether or not EVAR is standard of care. And if you look purely at the statistics, licensed vascular surgeons, educated and who have taken an oath to do no harm, choose endovascular care to treat their aneurysms more often in well-resourced healthcare systems than any other modality. So, is EVAR standard of care? Unequivocally, yes. The larger question, though, is should EVAR be standard of care? And that's where Professor Bradbury and the discussion about the guidelines really comes into practice. NICE would have us believe that the randomized controlled trials are the strongest form of evidence that we should look at. However, if you look at the randomized control trials for endovascular repair in our field, they are very, very old. They use early technology, and they were designed in a time when there was an incomplete understanding of aortic repair. So in fact, they're not ideal. And when the outcomes were stretched to try and find long-term outcomes, what they found was a disadvantage for patients who were treated with EVAR. But that data is highly biased and probably wouldn't stand up to our modern practice. So is EVAR the standard of care? Unequivocally, yes. But it is not the only option, and we need to make sure that we pay attention to patients through their entire lifespan. We improve durability by planning a sensible repair, doing a staged operation, making devices that fail well, and combine open and endovascular surgery in a bespoke way. And finally, we need to collect data to make sure that we are auditing our practice regularly and that we are not contributing to the poor durability of endovascular repair over time.
I'm from a little place called Swansea in Wales. I'm a jobbing vascular surgeon that does an everyday job. I read the draft guidelines and was quite surprised to find that EVAR was only going to be used for REVAR, so ruptured cases. A bit worrying for me. We've been running an EVAR program since 1998 when I started in Swansea. We're a reasonably high volume unit. EVAR is only used if patients are fit for open repairs. They're EVAR 1 type patients. The configuration should be that of the IFU. We looked at the contemporary follow-up. We've modified that so we carry out a CT scan at 6 weeks with an ultrasound scan for comparison, and would only carry on with CT scanning if there's a possibility of an endoleak. We looked at live financial data based on EVAR and open aneurysm pairs over a 2-year period as we've reached a period of equipoise. So in conclusion, with the caveats that patients have to be fit for surgery, that the IFU is adhered to, and that a contemporary follow-up regime is used, our real-world fiscal analysis actually doesn't support the restriction of EVAR.
We performed the Cone-beam CT. It's HD CT performed with the IGS Discovery 7. And you can see the results are here on the screen. Can you see them? Do you have the fusion screen going to London?
Yes, there we have it, yes.
Yes, we do.
Okay, so go up, please, Dustin. Go up to see the proximal neck. So you see the proximal stent just below the SMA. Now go down, because really what we want to see now is the aortic bifurcation and how the limbs are open in the iliac, in the diseased iliac arteries. Vas-y, Dustin, dépêche-toi un peu, descends. So you see that almost nowhere because we flushed, and you can see that the plaque, but everything is nicely open thanks to the kissing angioplasty with 12/4. Can you switch to coronal and sagittal view, please? You see, we check that there's no conflict between the limbs and that the limbs are nicely open. Okay. One, and then the other limb. And now the coronal view, please. And you can see again that both limbs are nicely open, so I don't need to stent them. I'm happy with the way those limbs are nicely open in the diseased iliac. And finally, the 3D Vr reconstruction. And you can see that this is from the cone-beam CT we performed now. So you see how nice this 3D imaging is to assess technical success. So I know that this patient will not occlude a limb during the night and that there's no conflict between the limbs and they're nicely open. So this is what I really wanted to show you. We've closed the ProGlide system on both groins, and the patient will soon be out of the hypodrome.
So, Stéphan,
and
Roger
I'll meet you
here.
in London tonight.
Roger here, yes, we're looking forward to seeing you again. But Stéphan, before you do, I think we should explain a couple of things to the audience. We've heard from Tara. We are going to later have comparisons between more recent series and old series. And I think you've just demonstrated state-of-the-art, excellent forefront technology. But would you please explain to the Charing Cross audience, and you helped to, what is meant by cone beam? Can you explain how important it is to have three-dimensional knowledge at the time after you've deployed, and the era we've gone through where we had three-dimensional knowledge before, but not always at the moment of deployment. Can you please give us a little lecturette on that?
That's a very important point, Roger. I mean, 3D imaging now is used to select the patient, to design the endograft, to guide us throughout the procedure, and to check technical success at the end of the procedure. So if there was any issue, I would fix it right away. And so this will obviously reduce the number of secondary procedures for limb occlusion or for type 1 endoleaks. And also this will reduce the hospital stay and reduce the need for secondary procedure during follow-up. And at the Mayo Clinic, Gustav Odrich has really looked at and has big numbers to show that. And I think that is the way to perform correctly aortic endovascular repairs.
And Stéphan, this is a basic endovascular repair, but Gustavo Odrich has used it for complex with multiple anastomoses and still using cone beam has got extraordinarily good results. I think what I wanted to draw attention to the audience, if I may give this editorial, is this, before your eyes, is the advance which is taking place, which shows that Tara Mastracci was quite right. Is that all right, Tony? Silo?
Yes, I have a question for you, Roger. How, because you've been designing the EVAR-1 trial, how similar is the technology we see here to the technology that went into the EVAR-1 results?
I daren't tell you. You have no idea what it was like doing the first devices in 1993. Fishing wire, all sorts of things created in an operating room. Please don't remind me of it. This is where we wanted to get to. We hadn't got there then. The EVAR trials, we did not commence until 1999 when commercially available devices were there. It was the best we had at the time. It's not the best of today.
Just to recognize that everybody in the audience agrees that sac linkage during follow-up indicates successful exclusion of aneurysm from arterial pressure and has been shown to be a predictor of low risk of EVAR failure during the first 5 postoperative years. That is very well recognized also in the recent guidelines in the European Society for Vascular Surgery. In other words, sac growth during surveillance period represents a big concern. Let me to introduce what is the sac behavior using this new generation of device, the so-called Treovans, that is coming from the Terumo Aortic company. They're using the rational registry, collecting more than 200 patients, coming from 32 sites in 17 countries, with these particular highlights about the outcomes, early outcomes. 96% clinical success at 1 year, 96% freedom from surgery intervention, 95.5% freedom from endoleak type 1-3, 97.5% freedom from aneurysm expansion. Sac linkage during follow-up indicates successful exclusion of AAA and has been shown to be a predictor of low risk of EVAR failure. Sac expansion is related to endoleaks, reintervention, and higher mortality rates. Sac reduction over time is a primary indicator of success after EVAR. Not all the endografts show the same sac reduction, and Treovans have a high regression rate at 1 year follow-up and represents a new generation device to improve our trust in EVAR nowadays.
So we've heard in the previous session that EVAR remains blighted by aortic complications with around a 20% reintervention rate over 5 years. And treating type 1 and type 3 endoleaks prevents aortic rupture. Surveillance, therefore, is mandatory for EVAR. And the question is whether we can develop device-specific or patient-specific outcomes to guide surveillance. So the LEAR project tries to develop a patient and graft-specific method of surveillance. It looks at preoperative morphology, things that can happen in the operation, such as the development of an endoleak and treatment of an endoleak, and then looks at sac progression in follow-up. So LEAR provides a device-specific estimation of EVAR outcome, but more importantly, it gives a patient-specific view of surveillance. Changes in aortic diameter can predict future risk. And personalised medicine for EVAR is clearly going to be the next frontier in improving both the clinical and cost effectiveness of endovascular aneurysm repair, and in so doing improving the safety and efficacy of EVAR.
I want to build on the themes that Dr. Mastrossi introduced about the importance of healthy aorta as our proximal landing zone and what endovascular techniques have helped us learn about the biology of abdominal aortic aneurysm disease. I have no conflicts. Like many of us, we've really embraced the endovascular approach to aneurysm repair. You can see here our trends at Stanford University over essentially the time I've been on the faculty there. We still perform open surgery, but infrequently and mostly for revision of EVAR. So we had 883 consecutive patients treated with EVAR for de novo infrarenal abdominal aortic aneurysms. If we eliminated the complex or emergent ones, we're left with 500 patients. You can see proximal device diameter is less than 34 millimeters in almost 400 patients, and a larger diameter in a little more than 100 patients. You can see almost eerily similar results to those previously published by Hens Verhagen using a range of devices, not strictly the Medtronic Endurant, showing a nearly four-fold increase in proximal device failure or type 1 endoleak using this composite endpoint, suggesting the problem is not the device but the aorta itself. So in summary, there's been a steady improvement in devices and outcomes. Large diameter necks are not suitable for standard EVAR even if they're on IFU. We should consider fenestrated or branched EVAR when necks are greater than 30 millimeters proximally. Consider iliac branch device when the common iliac artery is greater than 20 millimeters. And as we've discussed previously in this session, follow-up imaging is mandatory.
So what we did was a systematic review in Copenhagen to decide if EVAR is a durable solution with the indications for reinterventions. And we started with 2,077 hits and ended up with 23 studies included in the quality review, and we found all these reinterventions indications that we all are aware of. EVAR is a durable solution. It has a wide variety of indications for reinterventions. Complications and techniques develop over time. So with the new stent grafts and with the excellent show you saw from Haulon in Paris, where you use cone beam CT, vascular tracing, or etc., there's a huge difference to a better outcome with new generations of stent grafts, and you have to maintain surveillance, and that has to be personalized in the future.
This presentation is a group presentation, as you're going to be able to see here, modeling cost effectiveness of alternative surveillance and reintervention strategies. These are the authors of this. And conflicts of interest. And these are required to be said. Now, Fiona, please.
Yeah, first we want to have a look what happened during the first and largest randomized controlled trials conducted here in the United States. What happened to the long year follow-up of 15 years displayed in these trials? We see that, of course, initially there was a benefit for EVAR, but EVAR compared inferior to open surgery during follow-up, especially in the period after 8 years. Another problem, and what we can also see on the slides, is that also the cause of that was secondary rupture in this observed group. So we have to look deeper into the surveillance of the patients. In the EVAR trials, the follow-up was suboptimal. In the first 6 months, 90% of observed patients were into the follow-up, but during 9 years, only 10% of survivors were adherent to the follow-up protocol. So we can see that the follow-up was suboptimal in the EVAR trials.
So is this only a UK problem? Well, I don't think so. Here we can see the situation in the Finnish series, and we can see that after 9 years, only 40% of the patients came back to annual CT. And this is for many reasons. It's because of engagement of the patients to the heavy surveillance, but also sometimes surgeon's decision. Current EVAR follow-up protocol is suboptimal. It's too heavy, it's expensive, and patients don't follow and engage into it. I think we can all agree that we need lifelong surveillance after EVAR, but it has to be patient-friendly, simple, and safe. So from our study, we saw that 85% of the patients that underwent rupture-preventing intervention within 2 years from the primary EVAR had sac growth in the preceding 2 years. Also, we found that 44% of patients that did not undergo rupture-preventing intervention or had secondary sac rupture had no sac growth in the preceding 2 years. So it seems that we are able to find the patients who are at risk of for future adverse events by following the sac diameter. Just have to find the optimal threshold when patient needs to be sent to a vascular center and CT.
The cost-effectiveness modelling that we have carried out can be broadly categorised into 4 steps. The first of these is to identify the events which we're interested in tracking and to see how we would like to join those together, what the relationships are between them. The second step then is to estimate the rates of those events, and we're going to do that using real-world data, firstly from the EVAR trials and then from a contemporary data series from Helsinki. The third step is to validate the model, and that means comparing the results from the model with what we actually observed in practice. And this will give us an idea of whether the model is capturing well what happened in reality and whether we can really have some confidence in the model we've built. The fourth step is then to simulate different surveillance and reintervention strategies using the model we have built, and then to look at the impact of that on key outcomes as well as costs.
We can see that strategy B, using if we run the EVAR protocol with perfect compliance, we would have a slightly better outcomes, but a much greater increase in costs. If we strategy C or D, using the European guidelines, would be much more effective than the EVAR1 trial, but we would again get a much bigger increase in cost. Strategy E, truncating follow-up at 5 years, would be neither the clinically effective nor the cheapest option because of the increase in reinterventions required. And strategy F is not the most clinically effective strategy, but is the least cost and the most cost effective based on NICE's published willingness to pay. So with using that strategy, we could reduce ruptures and aneurysm-related deaths, but we have uncertainty about some of this is modelling. There's much uncertainty about the costs and sensitivity or accuracy of using this handheld ultrasound scan in a primary care setting.
EVAR trials have inherent loss to follow-up. Potentially avoidable ruptures and aneurysm-related deaths occur. Real-world data with informing a model with good internal validation and exploration of impact of modern devices has been performed here, and alternative surveillance and reintervention policies could increase the life years gained of EVAR trials, and strategy F also offers possibility of reducing costs. Now there's one more slide. That's the one. I just wanted to re-emphasize this one, because here you'll see that in retrospect, on the left, those are the EVAR trial findings, And whichever of the follow-up protocols we trialists had designed at the beginning wouldn't have been successful. Because A represented how bad it was, how cost ineffective it was, that protocol. Even if we'd used the guidelines of the European Society, C and D, it would have been so expensive, it'd now be found cost ineffective, and NICE would be making the same conclusion. So you can't blame NICE for that. Over on the right, you'll see that from Helsinki, with the current series, quite different, same model, same shape, as our brilliant statisticians and health economists have just shown you, but movement to the right along the horizontal axis. So that tells you that in those years, new devices have been performed, new imaging, new reintervention techniques. We don't know what did it, but what actually happened is a measurable change, and the whole lot has become improved in many ways in terms of mean quality adjusted life years. But even then, the use of the handheld Doppler in the community, F, would be the cheapest. And I've listened to all of the caveats of the scientists, but as a mere clinician, I'm going to go beyond that. I'm going to show you the device that's going to revolutionize endovascular repair. This is a probe by Butterfly. John Martin has brought it across from California. I'd heard about this. He's brought one. And this can work off a mobile phone, an iPhone, and it will be possible in the community to measure the diameter of the aorta. For sick people who did not want to go to hospital, average age of 74 years, they will be able to measure annually their diameter, if not one of their relatives, if not at the local surgery, if not by a vascular scientist in the community. We shall then know the diameter of the aorta. We hope in future, you've just heard how EVAR will be kept safe, and the patients who have complications will have leaks. The leaks will lead to diameter change. We'll recognize that. They will then go into hospital for CT scan and correction by the latest techniques. Thank you for your time, and apologies for being late.